So if you guys are on Menti, I've just started with a SBA. So don't worry if you don't know this, but yeah, just have a start. And Anesh, can you just tell me when they answer?
Yeah. So if you want to join Menti, the code, as I put in the chat, was 8776160. Or have a go at this question. You can do it from your phones if multiple of you are on one laptop. You don't need to log in or anything. It's super simple. It's just, if you commit to an answer, if you get the answer right, that's great. If you commit to an answer and you get it wrong, you'll remember why you got it wrong. If you don't commit to something, you're less likely to remember it. So just have a go.
This is kind of to see where you guys are at anyway, like it's not, because I'm going to go through all this later, obviously. So
we'll give you another 30 seconds. Okay, so everyone's gone with Alzheimer's.
excellent. Okay, does anyone want to oh, hold on. Okay, does anyone want to like say or type in why they thought it was Alzheimer's over the other stuff?
We didn't think it was Parkinson's because that's motor disturbances. I remember frontotemporal dementia has mood like implications, like aggravated. I don't think it's delirium, and I don't know why I didn't pick Louis' body, but I didn't.
That's great. Yeah, that's very good. Yeah, that's a good way of thinking about it. So I'm going to go through all these different types like further on. So I'm just going to leave it there for now, but you are right that it's Alzheimer's, and it will become clear when we go through the presentation, like why that's the case. So obviously this whole talk is on dementia. So it's basically a neurodegenerative syndrome, and there's kind of decline in lots of different areas, and as there's loads of different subtypes, kind of the subtype that you have, there's decline in a more specific area, or certain symptoms will happen first, and that's how you can kind of differentiate between them. And the important thing about dementia, which will become like more obvious later, is that it's over months or years. So if something's happening over hours, it's never going to, the diagnosis is never going to be a dementia thing. So I'll just show you the subtypes because most of them are on that page before, just to give you an idea, and we'll go through them later. Does anyone, so dementia can also be reversible, as in you can have those sort of symptoms. Does anyone know what kind of things can cause dementia, but it's a reversible thing? So there's several different causes.
Alcohol?
Yeah, exactly. And do you know what vitamin you get decreasing because of alcohol?
I mean,
yeah, exactly. Well done. Yeah, good. Anything else? Kind of on the same vein as like low vitamins.
Maybe.
Say that again.
Wilson's, have you got treatment for it, I guess, maybe?
Yeah, that's a good, yeah, that is a good, yeah, that's, I mean, yeah, Wilson's does cause neurological problems because of the copper. But in terms of like, not really like a condition, but like other vitamins that can be low that can cause this, or hormones. Don't worry if you guys don't know. There's quite a few. So essentially, low thyroid hormone, B12, folate, calcium, low things of all of these substances can cause dementia as well, or dementia-like picture. And also, in terms of like trauma, subdural hematoma can cause it, and normal pressure hydrocephalus. Does anyone know, if you've done past yet, what the three things are for, like, it's like a triad of symptoms? Does anyone know what they are for normal pressure hydrocephalus? Or one of the symptoms? No? Okay, so
this is my favorite triad.
Yeah. So the way that you'll like remember it is that they say wacky, wet, and wobbly. So wacky because they have dementia, wet because they have urinary incontinence, and wobbly because they get gait abnormality. And this is like such a, like, you'll, as soon as you know that triad, you're going to be able to pick that up in questions so easily. But yeah, this is just something to keep in the back of your mind when you're thinking about dementia. Just think about that condition. Okay, so if we're thinking about diagnosing dementia, what kind of things are we going to want to do? Like, we're approaching a dementia patient, how are we going to figure out what they've got? What kind of things?
I guess right at the start, like an acute mental state test or something like that.
Yeah, that's a good idea. And just something you would do for every patient, regardless of if it's dementia, like anyone coming in, what's the first thing you always do when you're trying to figure out what a problem is? Yeah, exactly. Oh, sorry, I didn't see the chat. Yeah, take a history. Exactly. And we're also alongside that going to do an examination. So I'll just show you this is like kind of a good way to think about it. So obviously you're going to take a history. You're going to do, like you said, like what Zach said, like there are various like mental state exams that you can do to figure out what kind of dementia a person has. Examine them. That's also kind of ruling out things like stroke and like subdural hematoma, just see if they've got neurological signs. And medication review, because certain medications can cause dementia-like symptoms. And like I said, the previous page, all the reversible causes like hypothyroidism, B12, etc. So that's kind of the order in which, like, if you're going to structure it in your mind, you can approach someone. Okay, so I just went up there, but like a collateral history is really important with dementia, because obviously if someone's a bit confused, they're not going to be able to tell you, oh, a year ago I started forgetting or misplacing things. So that like is especially important when you're suspecting dementia in the patient. Does anyone know in dementia generally, like Alzheimer's especially, what kind of symptoms indicate that the patient is in quite late disease, like it's progressed quite a lot? Kind of a broad category, but
is it their short-term memory goes?
Not quite. So that I mean, I suppose that might happen a bit later than long term, but it's not. It's more like, yeah, like you said, personality changes, so like mood changes. So when people are getting agitated, they're kind of like aggressive, or maybe they're just like apathetic, like they just don't really care. That normally signifies it's like a late stage of the disease, basically. And yeah, so like Zach said, like the cognitive testing, these are just examples of some. The only like cutoff I remembered was the mini mental state exam, the MMSE, which is if they've got a score of 24 or below on that, then it kind of points someone like they're more likely to have dementia, basically. And yeah, like I said, medication review, so anticholinergic drugs especially can be culprits with causing dementia-like symptoms or causing it. And like I said, reversible causes. So what kind of thing can you do to rule out those reversible causes we talked about? Like really basic, like what kind of tests? So like B12, thyroid, things like that.
Yeah, like so I guess like blood tests.
Yeah, exactly. Yeah, so basically, if you're on primary cares and if you're on GP, the kind of nice guidelines say that they want you to do a blood screen, basically, because you need to rule out that it's reversible and can be treated. And so obviously that'll be like full blood count, U's and E's, kind of the full works. And then if you're in secondary care, so if you're in the hospital, you can order like more specific tests like neuroimaging, so MRI, CT, obviously if you're thinking of like a brain bleed. So that kind of thing can be really helpful as investigations there. Okay, so if we're going to talk about the specific causes, so Alzheimer's is the most common cause of dementia. And basically you're going to think about Alzheimer's if it's someone that's over 40. And the key thing to remember with Alzheimer's, especially with like SBA stems, is it's global impairment. So loads of their mental domains are affected. So their visuospatial skill, their memory, their ability to like talk and remember words. What's executive function? What does that kind of refer to? No? Okay, so executive function is basically planning things. So they kind of lose the ability to have like insight into the future of like organizing plans with friends or like going somewhere. So that's executive function, or like organizing their bills or things like that. And does anyone know what, I can't even pronounce that, anosognosia is? Okay, so that's basically lack of insight. So I'm sure you're all aware, like the patient just basically, for quite a while, they just don't know that anything's wrong with them, and that can kind of lead to things like agitation if people are constantly questioning them or saying, you know, that person's dead, or like, oh, you're not remembering things. So they themselves don't realize that they've got this like severe disease and they can't remember things. And like I said, the symptoms like mood changes and yeah, like you said, personality changes and stuff that might happen later. So they get a bit aggressive, or they could actually be kind of manic and euphoric, or depressed. It's very like independent. Also, just something to remember that there's no like standard, I think it's like says on NICE or something, there's no standard like history for dementias. Obviously every patient can present very differently, but this is just like the general points to take home. So I'm sure you guys remember, I think it was like second year must have been, there's genetic and environmental. So I think like a small proportion of Alzheimer's can actually be inherited in an autosomal dominant way, if I'm correct, but a lot of it is also, there's genetic factors, so it's kind of, there's genes that are involved, but it's not like you're going to have the genes and necessarily definitely get Alzheimer's. And the protein that builds up is beta amyloid, leads to neurofibrillary tangles, and essentially you get loss of acetylcholine, which is why with medications, anticholinergic drugs can cause the same effects of dementia. And essentially, like on histology, there's just going to be atrophy all over, which fits in with the concept of it being kind of globally impaired. Does anyone know what genetic chromosome? Yeah, when that was amyloid. Chromosomal disorder is a risk factor for Alzheimer's, and a lot of these people, like almost inevitably, will develop it when they get older.
Is it Down syndrome?
Yeah, exactly. Well done. Yeah, so Down syndrome. Basically, a lot of these patients will develop it in their 40s or 50s. Okay, so that's Alzheimer's. Going on to vascular dementia. So that is the second most common cause. And basically it's either small vessel disease related or stroke related. So like if someone's had ischemic strokes, multiple ischemic strokes or multiple hemorrhagic strokes. And the key thing in terms of like picking this out in a stem is that it's stepwise deterioration rather than like a gradual deterioration, which kind of fits in with the idea of like them having some kind of you know, like cerebrovascular event, and then obviously things are going to change straight after that. So it's not as gradual as like Alzheimer's would be. It's kind of stepwise, so it just decreases that in a stepwise fashion, if that makes sense. So obviously with these patients, CTs and MRIs are going to be quite useful because you're going to be able to see like if they've had a hemorrhagic stroke or something. So also along that vein, you're going to have focal neuro symptoms. So like what kind of things might that be? It's like similar to with a stroke.
Fast sort of symptoms then, if it's similar to stroke.
Yeah, exactly. So like, and things that are like very specific. So they might have specific sensory deficits after stroke, or motor deficits, or they might have like problems with their vision. So it's kind of like focal problems that you can pick up on neuro exam. And so yeah, the things I've listed there are just kind of other symptoms, like again, like speech, which you might get with a stroke. And also they might give you a hint of like they're kind of an arteriopath, meaning they're quite at high risk of things like strokes. So they might have chronic hypertension, or they might have a history of strokes before, things like that. So that's a kind of a way to think about it, so you can pick it out in a stem. And so Lewy body dementia. So Mark is going to talk about this a bit more when it gets to Parkinson's. Does anyone know what kind of a kind of hallmark of Lewy body dementia is, or like the kind of way that they might present, at least especially in SBA land? So essentially
It's in the chat.
Yeah, nice. Okay, sorry, I keep not looking there. Hallucinations, yeah, exactly. So visual hallucinations are such a classic kind of thing for them to put in the STEM with Lewy body dementia. They also get early impairment in executive function. So with Alzheimer's, that kind of inability to plan ahead comes a bit later in the disease course, whereas with Lewy body, they might present quite early with being unable to perform executive functions. And like I said, it's tied into Parkinson's because Lewy body dementia basically can progress to Parkinsonism, which means that they basically develop the symptoms of Parkinson's, but that's quite late on in the disease. And so, as the name suggests, with Lewy body, like histology, you're going to get Lewy bodies basically, and they're in the brainstem and in the main part of the brain. And if you wanted, NICE suggests, like, I don't think they'd ever ask you what scan you do, but a further test you can do is a SPECT, which is basically single photon emission computed, so like single photon emission CT, or like quite commonly called the DAT scan. You might have heard of that. And that's just like a further test you can do if you're suspecting Lewy body to like confirm it. Yeah, okay. So with frontotemporal dementia, as the name suggests, you're going to get frontal and temporal lobe atrophy, and it's quite severe. Like these patients have like 70% of their neurons get lost in these areas. So what kind of symptoms are you going to get if your frontal lobe and temporal lobe are atrophy? I think Sophie, you mentioned it earlier. What, like some of the stuff?
Changes in mood, behavior, get like aggressive, I think.
Yeah, and like exactly. So it's kind of like obviously frontal lobe is controlling your personality, isn't it? So it's like they basically have huge personality change, and it's a really like common one is they're disinhibited. So that might mean like, you know, like someone wakes up and their grandpa's like pissing on the front lawn or something. So they just don't have a concept of like what's socially normal, or things that they wouldn't do not previously, they kind of don't really care about. They think it's fine to do now. And yeah, so hyperorality, like I think that literally means like kind of trying to get more stimulation with their mouth basically. So like they might have like excessive like food craving or like mouth movements. And just something with frontotemporal is that their memory and their spatial orientation is preserved quite late, so it's not going to present in a classic way that like Alzheimer's might be, whether you're like, oh, they're forgetting things. With this kind of thing, it's going to be someone that's disinhibited and they've got personality change basically. And there's this kind of subtype called Pick's disease, and I mean all it says in the handbook is like it is frontotemporal dementia, but on histology you find Pick's inclusion bodies, and those are basically like aggregations of tau protein, which is like what you find in Alzheimer's as well, and you can pick that up with silver staining. All those stuff is in the notes in the slides, don't worry. Okay, so those are basically like kind of exam fodder, like the ways you're going to be able to pick out what type of dementia people have. Like those are the key things to think about when you're trying to remember the subtypes. So I put dementia and delirium. I put delirium as an option on one of the slides before. So in hospital, there are these two scales you can do to, if you're trying to distinguish if they're in delirium or if they've got dementia. You don't need to know like anything more about it except from those two of the scales you could use to distinguish. So does anyone know how delirium presents differently to dementia, like what the symptoms are like with delirium?
Is someone with delirium going to be drowsy, or are they going to be normal?
I guess more drowsy and kind of hallucinating.
Yeah, so they're definitely going to be, they're going to be more drowsy. So the main thing is, they can present with confusion, but also with normal dementia as well, patients can be confused, and often are. Basically, the main thing you need to remember is that with delirium, it's an acute change. So it will literally be hours or days that they've they've started having these symptoms. Whereas, like I said, I emphasize with dementia, it's like months to years. So if someone's acutely become unwell and confused and like forgetting things, that's always going to be delirium when it comes to things like that. And like in general, that will always be delirium. So kind of one of the things to remember with delirium, with like it basically fluctuation of symptoms. So they're sometimes quite normal and their symptoms tend to be worse at night. They might have delusions, distractibility, which basically means you can kind of distract them from the fact that they're confused, or like they can like with the fluctuation, they can have periods where they're back to normal, it seems. And like Anush said, impairment of consciousness. So they're going to be like drowsy versus someone a typical dementia patient. But just the take home message is just remember, if it's an acute change, it's always like that's always going to more likely be delirium than it is going to be dementia, because dementia is over months or years. It's a long-term process. Okay, so I've got another SBA.
I think it's also just quickly mentioning that it's very common in a hospital setting where you have someone who has a diagnosis of dementia but will also have an overlying delirium. So it is very important to ascertain what their baseline is, and the best way to do that, of course, is to talk to their family and get a collateral history.
Yeah, exactly. And I think two of these scales, like one of these is actually used to distinguish someone that it's like it can basically tell apart if this person just has delirium or if they have delirium on a background of dementia. So they might use one of those assessment scales. But yeah, like with dementia, the most important thing is that you get a collateral history to see what their baseline is and like how acutely they've changed. So this is the next SBA, I think. So Anish, is that on Menti? If you just want to vote on that.
I've put the code for the people who just joined again.
Okay, thank you.
I corrected some spellings when I transferred it to Menti.
My bad.
It's okay. No one can actually spell anything in real life, let's be realistic.
Oh, is it Donna Pazil? I put A, didn't I? In the third, fourth one. That was not meant to trick you out. That like just assume that's the same drug in the first.
Yeah, it's funny. Yeah, you spelled it right the first time around. I'm assuming that was a typo.
Yeah, I mean, yeah. Let's assume it's a typo.
Let's assume it's a typo. Okay, so most people have gone for Donepezil alone.
Okay.
And then less people have gone for rivastigmine and risperidone.
Okay. So does anyone want to say why? Anyone that's chosen D, do you want to say why you've done that? Or actually, what do people think this patient has got? What do you think is going on here? Anyone? You must have known what the dementia was to get the correct answer.
Is it Lewy body dementia?
Yeah, exactly. And why? What kind of things are pointing towards that?
The hallucinations and the where has it gone? The like problems with paying your bills and stuff, like the executive. What do you call
Exactly.
it? Yeah.
Executive function. Yeah. So yeah, exactly that. So she's got visual hallucinations. She's kind of got emotional symptoms as well quite early, and her first symptoms are executive function issues, which, like I said, that happens earlier with Lewy body and not late. So basically, for those that put D, that is correct. Basically, the thing to remember is you don't give antipsychotics if you think someone has got Lewy body dementia, because it basically can tip them over into irreversible Parkinsonism. So that's like a huge no. So that's why I kind of put all those in. Just out of interest, does anyone know what are olanzapine and risperidone? What kind of drugs are they?
Hint, hint. It's on this slide.
Yeah. So they're basically atypical antipsychotics. So they're 5-HT3 antagonists. And you can use antipsychotics, like people do use antipsychotics in the management of dementia generally. That's why it's so important to remember that when it's Lewy body, you're not going to do that. And essentially, we're going to go on to the management, but donepezil and rivastigmine are kind of first line. And so those two by themselves, I could have just put rivastigmine, that would have been fine. But galantamine, you don't give first line with Lewy body. So just to show you, that is literally the NICE guidelines summarized. That's all they give you. So donepezil and rivastigmine and galantamine are acetylcholinesterase inhibitors, because obviously, like we said before, in dementia you're getting less acetylcholine, so you're going to want to not break it down as much. So those first two you can just, I think that's obviously like a clinical decision, whatever the senior consultant thinks. But if you start with that and it's not tolerated, you can instead try galantamine. And then if that's not tolerated, you use memantine. And all of these drugs are used quite a lot, like across the different types of dementias, just kind of the order. So like acetylcholinesterase inhibitors are used quite widely in dementia management. It's just sort of the ones you're going to use first. And yeah, just like I said, as it is there in big capitals, don't give them antipsychotics. And I'm sure Mark will touch on that later. Oh, I don't know why it's come up like that. Okay, so just some other random things about like what you don't use. With frontotemporal dementia, you don't want to use, I'm actually not entirely sure what the reason is why, but you don't use anticholinesterase inhibitors or memantine. And you also don't use them in vascular dementia unless basically two things, where they've got Parkinsonism or you also think they have Alzheimer's, because as we'll come on to, you do give acetylcholinesterase inhibitors in the management of Alzheimer's, but that's quite fine print. Like that's not many things as an exception to remember, to be honest. So with Alzheimer's, yeah.
I think the reason you don't use acetylcholinesterase inhibitors is because I just don't think it's an acetylcholine based like pathophysiology.
Oh yeah.
Yeah, so I just don't think it makes any difference.
Yeah, especially with something like vascular dementia, where
especially
like
vascular,
yeah, it's vascular, so obviously that's not going to make a difference.
Yeah.
And then with Alzheimer's generally, so you use acetylcholinesterase inhibitors, like I said, and it's basically you can use either donepezil, rivastigmine, or galantamine as monotherapies. That like any of those three can be given first line. And then the only other drug you'd add is memantine, and that's basically if a consultant wants to like add another drug because it's not as well controlled, so you can add it onto one of those first line ones. Or if the first line, those three drugs are basically contraindicated, or the patient just doesn't tolerate them, you're not going to give that. And yeah, like if they have severe Alzheimer's, then you're going to want to add on memantine. So that was basically my whistle-stop tour of dementia. Does anyone have any questions? It's actually not super high yield, I say, because the subtypes is like you don't need to know huge amounts about the subtypes, but if you just learn like the key points I put on here, it's quite easy then when you're approaching an SBA to like to pick out specific symptoms or like the order of things that have happened. Kind of that's basically what points you towards a lot of the subtypes like Lewy body. Yeah, and like I said, with vascular, kind of like they might have focal neurology. Does anyone have any questions about any of that?
Yeah, I think if you learn what Dhivya talked about, you'll be fine for exams, because this covers everything that comes up on PassMed, and that's all that will come up in your exams about like dementias.
Yeah. And the NICE guidelines aren't actually huge at all for this. Like normally I would use CKS, which is like their summary page, but like their main long page on dementia it doesn't have huge amounts of it. It's like I've literally got a lot of this I've checked the NICE guidelines, and a lot of this is that. So like yeah, it's actually not as big. I think I thought dementia was going to be huge when I first started learning it, but it's not that bad. But yeah, that's basically all of mine. So Mark, if you want to take control, and he's going to talk about Parkinson's.
Oh, you guys are so lucky you don't need to trawl through NICE guidance because Dhivya's done it for you.
Yeah.
You guys ready? Do you want to take a minute break, or are you happy for me to just go on to Parkinson's? I'll take silence as a yes. So I'm just going to take you through the basics of Parkinson's disease today. There's not a lot to it. But I will touch on the Parkinson's plus syndromes as well, because they can be asked in SBA questions sometimes. Right. So main things I want to go through. Just a little recap on the basal ganglia. I'll talk about the pathology, and then concentrate a lot on idiopathic Parkinson's disease, the one that you'll commonly see. But then I'll touch on Parkinsonisms, so drug-induced and Parkinson plus syndromes, brief overview of how we diagnose Parkinson's, and then I talk about the pharmacological treatment. So, basal ganglia, I'm not going to dwell on this too much because it was covered in second year. If you don't remember, don't panic. Just take 10 minutes the next time you revise through Parkinson's, take 10 minutes just to go through the anatomy of the basal ganglia and the functions. But the overview is that it's divided into the corpus striatum, which is the caudate nucleus and putamen, and the pallidum, which is the medial and lateral global pallidus, the subthalamic nucleus, and the substantia nigra. And these are the components that make up the basal ganglia. Two distinct functions split into direct and indirect pathways, as demonstrated in the image on the left hand side of the screen. Direct pathway initiates voluntary movement. So when you want to outstretch your hand to pick up a glass, that's your direct pathway activating to tell you to initiate that movement or to help initiate that movement. The indirect pathway controls postural adjustments associated with voluntary movements. Okay. The pathology. Well, it's on the screen, so it doesn't point me asking, but main things, mostly sporadic disease. Hold on. Oh, sorry, I dropped there for a sec. Mostly sporadic disease. Predominantly what you'll see is an idiopathic Parkinson's, because it's a disease of aging. There do exist hereditary forms, so associated with genes like PARK7 or the GBA gene in Gaucher's disease. The main pathological findings found on autopsy predominantly is the pallor of the substantia nigra and the locus coeruleus. So in the image on the top right corner, you can see a section through the midbrain. On the right is a normal midbrain with the substantia nigra dorsal to the crus cerebri. And you can see that's quite dark because of the melanin that's produced by the cells in the substantia nigra, compared to someone with Parkinson's where there's a loss of those cells and it's quite pale. Okay, the main histopathological finding is a Lewy body, which is just aggregations of alpha-synuclein. These are usually intracytoplasmic, so they're within the cells. They're eosinophilic in color. They're dense core with a pale halo. So the white arrow there shows it nice and clearly a picture of a Lewy body. Just a little nice. This is a really good image of the pathophysiology of Parkinson's disease. So just in your own time, just take a look at it. Just remember it. It helped me remember a lot about Parkinson's as well. So the main things is damage to the substantia nigra reduces dopamine output, which affects the striatum, causing a reduced activity in the direct pathway, which results in the negative signs such as hypokinesia, so reduced slow initiating movement, and postural instability, right? And that's where they get the rigidity as well. The indirect pathway is also affected, and this gives you the positive signs. So the rigidity, like I said, the rigidity and the resting tremor, okay? Just a very quick whistle-stop tour through the difference between spasticity and rigidity. When you're thinking about spasticity, you're thinking about pyramidal lesions, so lesions of the corticospinal tract. Okay, so stroke, cord compression, motor neuron disease, all are causes of pyramidal lesions. Weakness is present, but sometimes might not be in certain instances. There's great resistance in the initial part of the movement. So this is where you get what's called the clasp knife spasticity, shown in the GIF on the on top. So there's a resistance to the initial movement of the leg, and when it gets to a point where it can't cope with the tension anymore, it gives way, inhibitory. This is also velocity dependent. So does when you're examining tone with these patients on a neurological exam, remember, always vary the velocity, because you want to see if the spasticity is or if the increased tone is velocity dependent or not, because that can tell you the difference between spasticity and rigidity. Rigidity, extrapyramidal lesions, so basal ganglia, predominantly. You get lead pipe rigidity, which, as it says, the limb is as stiff as a lead pipe, and cogwheel rigidity. Cogwheel rigidity is rigidity plus a tremor. So you commonly see this in Parkinson's, and I don't know why this GIF didn't load, but it is what it is.
If we show it on video, if we just show it on video, have a look at my hand for a second. So when you usually rotate a hand, it should be nice and smooth. So you're basically doing this. Be like to the patient, oh, I'm just going to shake your hand for a second, and you do this. It's nice and smooth. With cogwheel rigidity, what happens is you have the Parkinson's tremor, which is going at a set rate, and then it's also rigid, so you'll get a very jerky movement as you've got both the tremor and the rigidity. And you'll have to put a fair bit of force in order to get that.
Yeah, exactly. And it literally feels like their wrist is a cogwheel. It goes, stops, goes, stops, goes, stops. So when you feel it, you'll always remember it. And just another note, rigidity, it's not velocity dependent. Okay. So Parkinson's disease, like most things in medicine, it's a triad. So it's a neurodegenerative disease, and it's classified by a triad. Does anyone want to give me the 3 things that make up Parkinson's disease?
Or at least one of them. We have told you some.
Yes. I mean, if 3 people just give one, or one person gives all 3, I'm happy with whatever. Sophie, you were about to say something?
Rigidity.
Yes, very good. Rigidity.
Bradykinesia and tremor.
Bradykinesia, fantastic. Good job, Lauren, as well. Bradykinesia.
And tremor. Is that the last
Tremor,
one?
fantastic.
Okay.
No, those are the 3. So tremor, bradykinesia, and rigidity. Now, does anyone want to tell me, give me a definition for bradykinesia? Because there's one aspect of the definition that I usually forget, so I just wanted to make sure that people just want to help people remember it as well. Sorry, hypotonia is rigidity. It's just another way of saying rigidity. Difficulty in initiating movement. Yes, that's exactly it. So, as you said, Laura, it's slow initiating movement, but also reduced frequency and amplitude of that movement as it occurs. So, I'm going to turn on my video for a second, just to show you what I mean. So when you are assessing someone for rigidity, you can ask them to do a repetitive movement over and over again. So what I've been taught to do is ask them to do this, right, with one hand and then the other hand. And normally we can do it quite quickly, as fast as we can, and it's still a steady motion. But with someone with Parkinson's, it will be slow to initiate, right? And the amplitude of the movement will reduce over time, and the frequency of the movement will reduce over time until they can't do it anymore, okay? Any other clinical, I know the picture kind of gives away a lot of it, but does anyone want to suggest any other signs and symptoms that you'd see that they can think of with Parkinson's disease? Then maybe not be on this image. I think
there's a really good finding in the hand that you might have heard of, they might have mentioned in second year, that can give you the diagnosis as soon as you walk into a patient's bay.
Yeah.
That I don't think is on this image.
No, it's not. It's not on the slide.
Any ideas?
Pill rolling, exactly, Zachary. It's pill rolling tremor. So it looks like they're rolling a pill in their fingers. Anything else? I think most of it is covered here, so I might actually just reveal. So, like you said, pill rolling tremor or resting tremor. They're usually stooped over because of the truncal rigidity. Flatten affect. Anyone want to? Does anyone know what flatten affect means? So flatten affect is usually just a very stoic, doesn't react to emotionally, as you can see on the face. So a very stoic face, although it may be unintentional. They're narrow, shuffling gait, loss of arm swing because of the rigidity, and then, like I said, lead pipe rigidity of the distal limb and cogwheeling because of the superimposed tremor. So that's the basic overview of Parkinson's disease. Next, I want to talk about drug-induced Parkinson's. So it's basically Parkinsonian features that are due to medications that alter dopamine transmission. Can anyone throw out a medication, a common medication that might cause it? It was mentioned in Dhivya's slides. Metoclopramide, yeah, it's good. One of the common causes we see in geriatrics is the patient will be on metoclopramide for a long period of time, and they might develop drug-induced Parkinson's. Good. Any other medication? We use these medications to treat schizophrenia, or we can give it in acute manic episodes or in patients with Alzheimer's. So main treatment of psychosis. Anyone want to suggest any names? Yeah. So I think you're thinking of olanzapine or donepezil. It doesn't cause because it doesn't interfere with dopamine transmission. It doesn't cause drug-induced Parkinson's, but most of the antipsychotics do, particularly the first gens.
I think you've combined two of the drugs on that slide, which is quite impressive. Good job.
But I think you're thinking of olanzapine.
Nice.
Good. Other ones I don't expect you to get because even I didn't realize some of them. So the main ones are your neuroleptics or your metoclopramide. Methyl-dopa can also do it, and I didn't know this until I was reading Netters the other day. Amiodarone and valproate are implicit in drug-induced Parkinson's. There's another medication that causes a fine tremor, but doesn't cause drug-induced Parkinson's. And if anyone knows, drop it in the chat. If not, I'll tell you at the end. So you get all the features of salbutamol. Yeah, it causes a tremor, but I'm thinking of lithium. Lithium causes a fine tremor as well, but doesn't cause drug-induced Parkinson's. So with drug-induced Parkinson's, you get all the features of Parkinson's disease or Parkinsonism. Tremor is less likely. The symptoms are more symmetric than PD. So usually when someone comes in with idiopathic Parkinson's disease, usually they'll complain of stiffness or tremor on one side of the body or one limb. And then as it progresses, it tends to become more symmetric. The mainstay of treatment, stop the agent and follow up for improvement. So stop the metoclopramide if they're on metoclopramide, switch them to another anti-emetic, and follow up to see if they improve. So next I'm going to talk about some of the Parkinson plus syndromes, one of which is progressive supranuclear palsy. I've enclosed the original name. I'm not going to bother trying to pronounce it because I can never say it fully. But if anyone's just interested in what it originally was called, it's again another neurodegenerative disorder, unknown etiology. There's Parkinsonian features. So again, tremor, rigidity, bradykinesia. But in this, they get a supranuclear palsy. So yeah, in this, they get a supranuclear gaze palsy. So they lose the ability to look up. So when you do cranial nerve examination, be sure to observe. So if you see someone with Parkinson's, always do a cranial nerve examination as well, just in case that they might have a supranuclear gaze palsy, which they lose the voluntary vertical movements, okay, of the eyes. Although apparently the reflexive movement is preserved. So when they look up, their eyes will follow. But if they keep their head still and you try and get them to follow a pen upwards vertically, they have trouble doing it. They have a retrocolic posture. So retrocollis is in the picture as demonstrated. They have rigidity of the trapezius muscles, and they tend to be looking upwards, and that's a cause for them to fall. So a lot of these patients will present to A&E with falls. They also get dysarthria as well. Usually respond quite poorly to agents that we use to treat Parkinson's disease. So that kind of, if they present initially with tremor, rigidity, bradykinesia, you're going to put them on. The people are put on dopaminergic agents to try and treat these symptoms. If over time they don't respond that well, it's kind of an inclination that it is a Parkinson's plus syndrome. It is something like progressive supranuclear palsy, or what I'm going to talk about next, multiple system atrophy. So MSA, again, another neurodegenerative disorder. There are three main types. For the exams, the only one you're expected to really know is Shy-Drager disease, or Shy-Drager syndrome, which is multiple systems atrophy A, predominantly affecting the autonomic system. So this is, you get Parkinsonism with or without cerebral ataxia, but pronounced orthostatic hypotension. The other two you can have a read about in your spare time as well if you're interested. But they're either Parkinsonism with autonomic dysfunction or cerebral ataxia with corticospinal signs and dysarthria. And like I said, similar to progressive supranuclear palsy, they respond poorly to dopaminergic agents. So Izzy, help me put this together.
It's probably worth asking, what is the medical definition of orthostatic hypotension?
Good question, actually, yeah. Anyone want to give it a shot?
Sorry, can you repeat the question, please?
Yeah, no worries. What's the definition of orthostatic hypotension? So I'll go back. No, it's not. But yeah, orthostatic hypotension.
So there are two cutoffs that they'll ask you about in exams. So if they gave you a scenario with MSA, they would be like, this person's blood pressure was this when sitting, then this when standing. It's one of the cutoffs you do kind of need to know.
Laura, it's orthostatic hypotension is another way of saying postural hypotension. But do you know what so it's hypotension when change in position. So when you stand up from a lying position, you get hypotension, you get a drop in your blood pressure. Does anyone know the drop that yeah, exactly. It's can be due to autonomic dysfunction. So you don't respond to your baroreceptors, or your afferent pathway doesn't respond to the sensed drop in cardiac output because of the change in position. So does anyone know what drop, how many millimeters of mercury of pressure do you have to drop for it to be considered orthostatic hypotension? 40 is a bit much, so it's usually 20. So a drop of 20 millimeters of mercury on standing up is considered orthostatic hypotension. And you measure it when they stand up. I believe you measure it at the 1 minute mark, the 3 minute mark, and the 5 minute mark. Anish, am I right, or am I mixing it up?
Yeah,
Yeah,
you usually do it, but in an exam they'll give you one of them, and you just go off the one reading that they'll give you in an exam.
Yeah, but you should measure it usually at 1, 3, and 5, or that's what people will ask you to do. So Izzy's helped me throw together a couple of these images. Does anyone want to shout out what they see? So in the left-hand side, the two pictures of, on the left top corner and the left bottom corner. What kind of sign do you see in these pictures?
Is it masked facial expressions?
Yeah, exactly. Good job. So yeah, it's masked facial expressions. Is the flattened affect or the Parkinsonian face. So it's very stoic. They aren't showing any emotion on their face. So good. Good. How about the middle top one?
Stooped posture?
Very good. Middle bottom. Anyone want to give it a go?
Hallucinations?
Very good. Hallucinations. So you see those in what Dhivya was talking about earlier in Lewy body dementia. Okay. Top right. You don't have to give me a medical term. You can just say what you see, even in just layperson's terms.
Sweat?
Yeah, sweat. So hyperhidrosis. And bottom right.
The hydrosis thing off.
Sorry?
Urinary incontinence?
Yeah, urinary incontinence or urinary obstruction, retention. Sorry, urinary retention as well. So this is a suprapubic catheter. Some patients with Parkinson's might have it. Some patients may just have a long-term intraurinary catheter. But yeah, so either incontinence or retention. Sometimes these patients will present with. Good. So Lewy body dementia is an umbrella term for two distinct things. So either it's dementia with Lewy bodies, so like Dhivya was talking about earlier, or Parkinson's disease with dementia. So I'm not going to dwell too much into it, but the main thing is with dementia with Lewy bodies, you get pathological Lewy bodies in the cortex, not just the basal ganglia. It's dementia plus Parkinsonism, sometimes with psychosis. So that's why we put up the picture of hallucinations there earlier. And the timeline is important. So the dementia appears first, and the Parkinsonism, so the motor signs, appear later on in disease progression. Whereas Parkinson's disease with dementia, the dementia occurs in someone who already has established Parkinson's disease. Okay? Does that make sense? I always get confused between the timelines with the two. So it's the main thing to remember: dementia with Lewy bodies, dementia first, Parkinson features later, Parkinsonisms later. Parkinson's disease with dementia, patient already has Parkinson's disease, they develop dementia later. Okay? There are other secondary forms of Parkinson's disease. So you can have Parkinsonism secondary to vascular disease, post-hypoxic injury to the basal ganglia, post-encephalopathic injury, cortical basal degeneration, which is a rare form of neurodegenerative disease. I think in SBAs, they will talk about something called an alien limb. I've never seen it myself. I've only heard it described, and it's basically just a limb that acts of its own accord, without conscious effort. If it could be something they throw in an SBA if they really want to throw you, or they want, it's a gold standard question. It's not a gold standard, a gold medal question, but highly unlikely that'll come up. But if you're interested have a read about it. And it can also occur in head trauma. So the image on the right side shows which famous boxer who developed Parkinson's disease, and it is believed that he developed it because of the repetitive head trauma due to boxing.
I love trivia.
Yeah, there you go, Muhammad Ali. Good. So yeah, it's Muhammad Ali said to have Parkinsonism secondary to repetitive head injury. Next, we're going on to the diagnosis. So predominantly, it's a clinical diagnosis based off the triad and other clinical suspicions. Like I said, so in PSB, you've got the gaze palsy, and in MSA, you've got the autonomic dysfunctions. The other thing you should do, so a thorough history and examination, like most things in medicine, is the most important thing you can do. The next thing, so if you're suspecting that this is drug-induced, always do a good, a thorough medication review, and stop, the offending agent if you think that's what's causing the Parkinson's, and then follow up. If a patient isn't responding to treatment, like I said, that's kind of in favor of these Parkinson's plus syndromes. And the other thing that Dhivya mentioned is a DAT scan. So this is 1,2,3-ioflupane that binds and images dopamine transporters in basal ganglia. So it's used to differentiate Parkinson's disease from other motor syndromes such as essential tremor. Because in essential tremor, the basal ganglia aren't affected, but it's poor differentiation between Parkinson syndromes. So because the basal ganglia are affected. So it helps to tell you that it's definitely Parkinsonism, but it doesn't help differentiate between other Parkinson's disease. It's an expensive scan and people rarely do it, I think is the thing to put in. So don't worry too much. I mean, no one's going to ask you to interpret it. I mean, you can suggest it if further down your investigations, but no one really does it. Anushi, did you want to say something?
No, sorry, my internet's just dying.
Oh, it's okay, no worries. Next, we'll go and talk about the treatment. So, you guys might remember this from your pharmacology in second year. Levodopa is first line in elderly patients. And that's because it tends to lose its effectiveness over time. So you want to save it up for younger patients until later disease progression. It's used to treat the rigidity and the bradykinesia, but it has on-off effects. So patients may fluctuate during the day, where at one point they're doing really, really well, and the next minute they're very rigid and stiff and slow to initiate movements. There's also end-of-dose deterioration. So you might notice when you give a patient their Cinemet, right? Which is the brand name, by the way, because I was asked this 3 weeks ago when I was on geriatrics. I was asked what Cinemet was, and I just stared blankly for about 5 minutes because they like to use the brand name when it comes to levodopa for some reason. When you first give your patient the Cinemet, you'll notice that there's this peak. When it reaches peak concentration, their symptoms are minimal, but towards the end of the dose, they start to deteriorate a bit. So they get more rigid. The tremor starts to come back a bit more aggressively. So that's another thing to keep in mind is when you go to see a patient with Parkinson's, or before you examine a patient with Parkinson's, have a look in the drug chart and see when they were given their levodopa, if they are taking levodopa. Another thing you can give is dopamine agonists, so ropinirole. It's first line in the younger patients, like I said, because you want to save up the levodopa for later on in disease progression. And its mainstay is to treat the rigidity and the bradykinesia. You can use anticholinergics to treat the tremor, so try hexafenadil. There's other drugs, so you can give dopamine releasers. Yeah.
Just worth mentioning if you go back a slide.
Sorry?
If you go back a slide, it's just worth mentioning. Yeah. So when you start someone on ropinirole, a very, very oft forgotten side effect is you get disinhibition because of this increased dopamine, and you get like crazy activation of like reward pathways in the brain. So these patients might go off and do some really, really, really random stuff. Like it's very common that these patients come back with sexually transmitted infections, or will go away and gamble away their entire life savings. So it's very important that you warn them about this and their families.
Mm-hmm.
Like it happens, and
yeah.
people, and they don't teach about it so much, but like it's super important.
It's really important. And actually, I'd forgotten that's the case, because it follows. Does anyone remember the biological pathway, the reward pathway that dopamine stimulates and causes this kind of behavior? And these patients may come in with psychoses as well, because it's kind of these opposite effects. Yeah, the mesolimbic system, mesolimbic pathway. So it's kind of it's interesting to see. So you can give a patient with psychosis neuroleptics, and they come in with drug-induced Parkinsonism, but you may be treating a patient's Parkinson's disease, and they may come in with psychosis secondary to that as well. So that's actually a very good point. Thanks, Tanush, for adding that. I completely forgot to write that down. Dopamine releasers. So amantadine is another drug you might see. It's used to treat milder disease. And COMT inhibitors. So COMT is an enzyme that's used to break down dopamine, noradrenaline, adrenaline, and I believe serotonin as well. So the main reason you're giving COMT inhibitors is to prevent the breakdown of levodopa, so that it's longer acting. So it's used mainly to treat fluctuations on-off symptoms and dose and prolong, to stave off end-dose deterioration. So we can give it as a combination therapy with cocaraldopa or levodopa to prevent the breakdown, to prolong its action. So you can get these combined formulations. Stalevo is one of them. Just to mention on levodopa, it's usually given as a combined, so it's given as carbidopa and levodopa. Does anyone know what carbidopa does? If not, it's okay. It's to prevent peripheral breakdown of levodopa, because what you want is it passing through the blood-brain barrier to reach the basal ganglia. And by giving carbidopa, it prevents peripheral breakdown of the levodopa to dopamine. So like I said, drug-induced yes, exactly. Good, yeah, good job, Laura. It's a dopa G-carboxylase inhibitor. Drug-induced Parkinsonism. Way we can treat that is by, like I said, withdrawing the offending agent. What we suspect. Vascular Parkinsonism. Cocaraldopa is basically just a combination. It's carbidopa plus levodopa. It's another form. Yeah. It's just carbidopa plus levodopa. The brand name for carbidopa plus levodopa as well is Cinemet. So as I was saying, vascular Parkinsonism, you can do secondary prevention to treat the underlying vascular disease. It might not help with the Parkinsonism, but it will slow progression of other vascular associated lesions, and may even, if the Parkinsonism is vascular in origin, may also slow the progression of the disease too. So main take-home messages: remember the difference between spasticity and rigidity. Parkinson's disease is a triad of things, so tremor, rigidity, and bradykinesia. Have a go of remembering the Parkinson's plus syndromes. Have a little bit of a read of them in your own time, because they're also really interesting. I've seen one patient with PSP on my time in geriatrics, and it's actually really interesting to examine these patients. The diagnosis is predominantly clinical. So practice your history taking, practice doing neurological examinations on these patients. Because it's a disease of aging, there should be patients on most wards with Parkinsonism. So go on the hunt, have a look, see if you can find and ask to take histories and examine these patients. And remember, levodopa is your first-line drug in elderly patients. Save that as second in line in younger patients. So thanks to Izzy, I've got a SBA for you guys to complete. Anusha's dropped the code in the chat. Have a go, and Anush, you can see the results, right? So just let me just have a shot at it, and then we can go through it.
Also, like, this is like one of the few conditions you should try and make sure you examine a patient with by the end of the year.
Definitely, because these are patients that could easily be used in OSCEs, because usually they're, when they're first diagnosed, they're usually quite well. They're happy to come in. A lot of them are happy to come in and take part in the examinations, and it's easy clinical signs that are quite obvious to pick up on. So go onto the wards and find the patients to take histories and examine, particularly in your neuro rotations, if you're not at like Queen Square, where you get predominantly a lot of the rarer stuff.
You might see this in like a general medical ward as well.
Yeah, easily. I mean, the general medical ward I was on for Jerry's, I saw 3 or 4 patients with Parkinson's.
I'm sure if you need signs and you're at the Royal Free, you can just go and find Marc and he'll know where the patient is.
Yeah, if you find me, I'm happy to point you in the direction of signs when I'm in.
Same at Barnet, but no one's coming to Barnet.
Yeah.
Right, so answers. Majority of people have gone for idiopathic Parkinson's disease, and a few people have gone for multi-system atrophy.
Okay, so whoever said multi-system atrophy is correct. Does anyone want to tell me why it's multiple systems atrophy? Or whoever put down multiple system atrophy, can you give me a shot at why you put it down? Or what in the SBA kind of triggered you to think that? Yeah, general autonomic problems. So the thing that's making you think towards that is the having to be intermittently catheterized recently. So having to be intermittently catheterized suggests she's suffering from urinary retention, right? So that's suggestive of an autonomic problem. So it definitely rules out post-encephalopathic, rules out Lewy body dementia, rules out drug-induced Parkinson's, and definitely idiopathic. But that being said, she could have autonomic dysfunction due to another reason. She could be a lot of elderly people suffer from urinary retention for other reasons. So it's not the most friendly SBA because of that. But you're right in saying multi-system atrophy. But good job. So
I'm just going to put the feedback link in the chat. So as usual, be as critical as you can be. If there's something you really liked, let us know. I'll probably release a list of like changes we've made based on feedback, maybe like this weekend or something. We do read it. Like Marc's made loads of changes based on your feedback from last time as well, as you probably noticed.
Yeah,
so,
I cut down the number of slides. That's the biggest thing that I learned from it. But yeah, no, please give feedback. It really does help. And it helps tailor. It ultimately benefits you guys as well. Dhivya's put the QR code and everything for the forms on the slide, so have a go at it. And does anyone have any questions? Any questions about Parkinson's? Anything we can answer about dementias, and anything about fourth year in general? I'm happy, and I'm sure Anusha's happy to answer.
Just one thing I was saying earlier, I think. So we were talking about books and SBA books. There is a super underrated book that nobody will ever tell you to use. Wait, let me stop recording.
Is that HB's book?
Yes.
Yeah. I've got it here.